Melbourne, Florida. Our patient today has lumbar facet syndrome, which is pain emanating from the facet joints at L5-S1 on both sides. We're going to start with the left side, then we'll move over to the right side. I've placed 2 needles. They are at the junction of the transverse process and superior facet. I'm going to go ahead and I've made an incision. I'm going to go ahead and bring down the guide wire into the first one, and once I have the guide wire in place, I'm going to bring the scope down. You can see that the guide wire is right where the L5 screw is shot. So the L5 screw is going into that pedicle of L5 on the left side, and we're just lateral to the screw. We're coming down with our dilator now. I want to try to keep the guide wire shot where it's supposed to be. There's another needle at S1. You can all see that as well. Shot. The S1 we're going to get to next, but we're going to start with this L5. Shot. So people do this surgery differently, and I like to use needles and guide wires because I think it's safer. Shot. All right, so I've got my dilator tip right at the junction of the superior facet and transverse process of L5 on the left side. This is I'm going after the medial branch of the dorsal ramus. There's a nerve there that goes down and innervates this joint, and that's the nerve I'm going after. The procedure is called a rhizotomy. There's different ways to do rhizotomy. Shot. Let's go with a lateral view, or let's go with an oblique view, I guess. Let's just take a look at the oblique view. All right, let's go with a lateral. So I'm using the X-ray machine, and whenever I say shot, Chet, what I'm saying is take an X-ray picture. So that means switch over to the X-ray feed. Now, Chet is our head of our IT, but Chet has graciously agreed to help me with the broadcast. So, all right. We don't have a videographer currently, so Chet is fulfilling that role. Now, what makes this difficult is the fact the patient's already had a fusion with screws and rods, and you can see the screws are at L4 and L5. So we're going after the dorsal ramus, medial branch of the dorsal ramus at L5, coming down, innervating L5-S1. And it looks like it's in good position. So at this point, I'm going to remove and what happens is as soon as I take my hand off, Coker, things move. So I want to make sure things stay anchored where they are. Shot. Looks good. Let's go back to an AP view. So we're not doing anything with the fuse segment. We're working below the fuse segment. And this patient has horrible pain in the facet joints at L5-S1. So he's already the needle, and that didn't work. And it's not uncommon because you see all that scar tissue that's around there is definitely going to affect the ability for the needle to kill the pain nerve to the joint. When you have scar tissue, it's very dense and it doesn't have any water in it. And those treatments require, basically, you have the laser? They require water, fluid, can you turn the irrigation on? Yes, sir. They require the tissues to be full of water in order to create plasma So when tissue doesn't have much water, you're not going to get much in the way of plasma. So it really doesn't work so well. Anyway, this is the facet, and a lot of inflammatory tissue around the facet joint. So now Dr. Patel is the one who does all of the grabber. He does all of the, get the laser ready. All of the needle procedures, but I do the endoscopic surgery. And as an endoscopic spine surgeon, that's just what I do. All right, so this is the area of the facet joint, and we're going to get the laser going. A lot of scar tissue here, and what that scar tissue is from, it's from the fusion surgery. Okay. All right. The laser's on. Yep. So I'm going to use this laser to basically.
Oh, that's the screw?
Huh?
That's the screw?
Yeah, you're right. That is the screw. That is the metal screw, guys. So that's sitting in the pedicle. Look at how the laser can melt the metal. Incredible, huh? Well, we know we're in the right place because obviously the screw goes into the pedicle, and that nerve is right out here in all the scar tissue. It's wonderful. It's such an incredible technology. So we're actually seeing the hardware from his old surgery. I think that's right here is where this nerve is. All in this area. No wonder why the rhizotomy didn't work. There's way too much scar tissue from the prior surgery. Questions from our audience. So we're performing endoscopic surgery. We're performing laser-assisted surgery, but it's called an endoscopic laser-assisted rhizotomy, and that is the screw, indeed, the cross-link and screw from his prior surgery. We didn't put that in, obviously, but we're not here to take it out either. We're here to basically treat this nerve that's down here buried in all this tissue.
Should include a revision.
Huh?
Revision.
Right? No kidding. So it's clear why the rhizotomy that he had done before with the needle didn't work. There's just way too much soft tissue here. But what a wonderful procedure to do endoscopically, because the visibility is actually pretty good, as long as you don't get too much bleeding. Try to keep that to a minimum. All right. Now, I didn't do his original fusion. You can feel the bone of the transverse process right down here. You can see it right there. The nerve is probably not the nerve root, so don't get confused. We're not trying to cut the nerve root. We're cutting a branch off the nerve root that comes back and innervates the facet joint. And that branch is called the medial branch of the dorsal ramus. Okay? A lot of times it's more than one branch, it's a few branches, because the nerve will eventually split. Nice job, Luis. Boy, this is so thick. All scar tissue, yeah. And of course the nerve is in there buried. Some of these strands right here could be little branches. And my job here is to cut through that nerve. Now, cutting through the scar tissue is not going to hurt the patient. And the idea is to basically what we call transect the nerve so that it no longer brings pain signals. What is that noise?
The suction? What is that? It's a suction? It's a noise. You see it? Yeah, okay. Wait, can you do it better? On my left eye, it's kind of watery. Can you? Yeah, but wait, that's 4x4. Rita, you have more cantaloupe in standby? Cantaloupe standby? More? Cantaloupe? Okay.
I'm just marching my way down the transverse process where this nerve runs. And I think I'm out lateral enough at this point. Laser. Let me see. You can see the screw is there. And we're right on top of the transverse process. And I've transected the nerves that are moving along the TP. Would like to get another quick view with the X-ray machine. Right here, a quick AP. Just verify where we are, and then I'm going to finish up at L5, and I'm going to move down to the S1. And S1 has a dorsal ramus.
We need the X-ray.
That looks really good.
Oh, okay.
That's it over there, right? Which side is it, left or right? Yeah. Are you guys able to see that? That looks really good. Yeah, that looks really good. All right, can move the X-ray out for a second. Look, just swing it out that way. You don't need to bring it all the way out of the field. Scope on. Scope on. Up there, top, up top.
On the TV.
Hold on. All right, very good. So once again, we can see the hardware right there, and that's actually the screw called the pedicle screw. It's going into the bone right where the nerve runs typically. And as a matter of fact, the screw usually goes in right where the nerve runs. It's right at the junction of the transverse process and the superior facet. Let me come a little bit medial. Look at that, that's really good. I just don't see any nerve left. So this is all transverse process, and I've gotten rid of everything except for the screw, which we're not taking out. So I feel really good that we've gotten the nerve, the pain nerve, Most of you know this procedure as a rhizotomy. We're pretty much done here.
Lights come on, please. Lights on, please.
Yeah. Where's the suction? Go ahead and turn the suction on. All right. Scope's coming out. Okay, so that's one down. I'm going to pull this out and put some pressure, and then we'll do the next one. Bring your fluoro back in. Don't take the fluoro shot yet. I need to make sure the needle hasn't moved, Luis. Tell me when you're ready to take the fluoro shot. So we've done L5, medial branch of the dorsal ramus. Next is going to be the S1 dorsal ramus. Watch your arm. I think you're too far to your side. Yeah, you need to come more to my side. But that needle looks perfect. Still sitting on the bone. Shot. That looks really good. Yeah, so my needle in the, at the sacrum is in the perfect spot, I believe. And I can move it a little bit. May need to move it up a little bit. No, it's in the perfect spot. All right, so the bottom screw is at L5 and this is at S1. So let's go ahead and place the guide wire. And if you look at the surgery, the needle placement, guide wire, those steps are pretty much similar with the laser, Duke laser disc repair. But it is different because we're not going into the disc. We're going onto the facet joint. And most people should understand that the number one cause of back pain, chronic back pain, is a disc injury. The number two cause is the facet joint. Shot? Yeah. Everything okay, Luis? Shot? Shot? All right. Shot. Looking pretty good. Go ahead. You got it? Grab the bottom. Yep. Watch your gloves. It'll pull your glove in. Can't move your glove out. Coker. Hold on. Shot. Move your hand. Is that it? That can't be. This isn't all the way down. All right. So we're sitting right on the sacrum. And I'm trying to bring this tube down. Shot. Now, why am I struggling to get this down? There's some soft tissue. It's looking better. All right. Go ahead, try to get it out. I'll hold the tube. No, yeah. I think you're going to need something. So now we're going to get the dilator out.
Oh, yeah, no, I need it. It's coming out. Can I?
Yeah.
All right.
Yeah. Nice job, Luis. What would I do without Luis? That's why it's teamwork. Shot? Teamwork to make the dream work. All right, once again, we're at L5. We're at the S1 now, and I'm going to go back in, and I'm going to, you're good, you can move out. I'm right where the base of the S1 pedicle is. This, sorry, the superior articular facet, not pedicle, superior articular facet,
Lights off.
or process they call it.
And handle on the TV.
And I'm going to be looking for that dorsal ramus. I really need to see. Okay, good. That's better. So, well, the nerve is buried in that fat. Let me just use the laser. I usually like the grabber for blood clot or excessive fat, but so just at 12 o'clock is going to be the superior process of S1. So I got to take this tissue off, and the nerve is going to be right in here. You can see how effective the laser is at getting through any type of scar tissue. There's really not a lot of scar tissue at this particular level because the surgery with the fusion was done at the level above. And this level here is actually pretty good. But there's still a lot of fat and other soft tissue. Look at that effect I'm getting, Luis. I wonder if that's... You think so? There's a branch right there we just zapped. Now don't confuse this with the nerve root. We're not trying to cut the nerve root. We're just going after a branch that travels up to the joint and gives it painful innervation. So the pain that this patient feels within their facet joint is not something they want to experience. It's not something good, and we're here to eliminate that pain. So this rhizotomy procedure is not something we discovered at Duke Spine Institute. It's something that's been done for years, but doctors that do this procedure are typically pain management doctors, and they use a needle. We're going beyond the needle. We're using a new technology, the endoscope and a laser, and basically cutting that nerve, that pain nerve. Yep, I got the bone marrow. Let me see the grabber. I'm going to wipe this. Just about done with this left side, and then we're going to head over to the right side. I think that's a crystal. You know? There's bone right there. Should be done in about 1 minute with this side, then we'll switch sides. I just want to make sure we get everything we can. give this patient as much pain relief as is possible. Your job is to mostly hold it anchored down, Luis.
Yes, sir. Yes, sir.
You know, so I can't come off the bone, but to let me move it around while it's anchored down. Does that make sense?
Makes sense, sir. Yes, sir.
So that's the superior process of S1. Why is this pedal stopping? Pedal. Let's get a quick shot. Come on in. Coker. Towards me. Get a shot. That's enough. That's enough. Shot. Rita, I really need you to put that x-ray picture up at the top so I can see it. All right. So I need to be further south. Let me see. Shot. All right. Shot. Yeah. All right. Now out. Scope on. Scope on. Take it. Grab her. That's fine. I think we've done everything we can. That's definitely a lens problem, Luis. All right, that should be good.
Alright. Scope off. Lights on, please. Thank you.
Scope off.
You need sucker?
Yeah. Suction. Suction's on. All right, we've completed the left side. As you can see, there's one incision for both nerves, and You can do separate incisions for each nerve, but I like to try to minimize the amount of incisions. The incision has to be 7 millimeters because that's the diameter of the tube we're using. The endoscopic tubular retractor is 7 millimeters wide. To get that in, I have to have a 7 millimeter cut on the skin. The rest of the tissues get spread. So the only cutting we're doing is the skin and then of course the pain nerve that goes to that joint, which we want to cut anyway. That's our job. We're here to cut that pain nerve. 2 of them as a matter of fact. All right, pressure here. I'll take that. Leave the other one. I'll take care of it. You just put pressure. All right, we ready? Let's see. You had some good marks there. Shot? Come on, Rita, we really need you to, you know what, Flynn, why don't you do it? I don't know what Rita's up to, but we can't keep waiting for her. I need to see that transverse process. Why don't you bring the machine a little towards you? Shot? So I'm a little bit higher than I want to be. Shot. A little bit too medial. Shot. That's better. You can see the transverse process there. Shot. Got to make my way down to right where that transverse process meets with superior facet, right where the screw's growing basically. Shot. All right, let's go with a lateral view. Just leave that for me. You work on that. All right, so I'm off quite a bit. All right, let's go back to a AP. That's strange. Are you getting the right AP view? Shot? No. I need to see the transverse process right where that bottom screw on the right goes in. Are you giving me the right view that Patel uses all the time? Yeah. So. Shot? Why am I still too medial? I guess I need to be a little bit more lateral. Shot? Let me have the coker. This thing is moving every time I move my hand. Shot? To me it seems like I'm high. Shot? Too far lateral. Shot? Let's go lateral. How's blood pressure? So it's good. Okay, so I'm just a little bit higher than I want to be. Shot? Too low. Shot? Shot? It's getting better. Let's go with an AP. So first I'm placing the needle at the L5 transverse process and shot and the superior facet. Shot. Okay, lateral. Feel the screw. Feels like solid bone there. AP. So I'm using this x-ray machine to get the tip of the needle right to where the junction of the transverse process meets the superior facet. It's the same place the screw goes in. I feel the transverse process. Shot? But I may be a little bit, like maybe too much on top of the screw. So I'm going to try a little more lateral. Shot? 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 Let's go lateral. For those of you who joined us late, we're doing endoscopic surgery on the spine. We're not doing a disc repair, we're doing something different. We're doing endoscopic rhizotomy, which is where we deaden the pain nerve that goes to this facet joint where the patient's having so much pain. He's had a fusion done in the past. I didn't do the fusion. Shot. Let's go with an AP. This looks lined up nicely on the lateral. Just got to get the AP view right. I'm trying to drop the needle in right where the transverse process touches the superior facet. We're pretty darn close this time. I can feel the bone. Feels good to me. Shot. Think we're right where we need to be. So I'm happy with that one. I'm going to now place the S1 dorsal ramus needle. Now this one is targeting where the S1 superior facet is on the right side. I've injected a total of about 5 cc's. Local. So now I'm going to try to get down to the sacrum to get the second nerve. Shot.
Doc, I got a question
Sure.
from YouTube from Edward. Can the pain also be associated with the S1 joint?
Shot. Can the pain be associated with an S1 joint, lateral? Well, you're talking about the SI joint, not the S1 joint, right?
Correct.
Yeah, the SI joint is nowhere near where we are. It's actually off to the side and below. So it's pretty far away. But pain can come from the SI joint for sure. Shot? I don't think it's coming from the SI joint in this patient's case. Shot? Need to be a little further north. Shot? Still need to be a bit further north, but not so bad. Shot? Give me an AP. It's a pretty good location there. Now right where that second needle is at the bottom, you can see there's an outline of the L5 inferior facet where it's articulating with the S1 superior facet. And that's actually really good right there. So I'm pretty happy with that. All right, we're ready to get started. So I'm going to start again with the L5. I'm right on the junction of the transverse process, superior facet of L5 where the screw goes in. And I'm going to take my needle out, leaving my guide wire. I've already made an incision. I'm going to bring my dilator down through the incision and track it down to right where that transverse process is. Again, a lot of scar tissue. Shot. You could feel it, Coker. Have the cooker ready for me?
Yes,
Shot. Yep. So I'm making my way down, and I'm going for the top half of that transverse process, right where it connects to the superior facet of L5. Pretty much where the screw is going in. Huh. So it's getting pushed lateral by the shot. It's getting pushed lateral by that screw. But that's all right. I'm going to redirect. I have some leverage shot. So pretty darn close to where we need to be. Feel like I'm on the bone there. Is it through?
no.
You sure? Hold on. Shot. Looks good. I'll do that. Now I'm bringing my tube down, my endoscopic tube. The tube is what I'm going to do the entire surgery through. There's a tiny little tube. Shot. This tube is 7 millimeters wide. Now we've been trying some different endoscopes. We use 2 endoscopes primarily at Duke Spine. One is cervical, the other is lumbar. And the shot, that's perfect. Feels really good. Go ahead. The lumbar scope actually affords better visibility.
Are we now okay?
Yeah. The cervical scope is smaller diameter. So it's actually, hold on. Actually move your hands, shot. The cervical scope is less invasive, but doesn't give you as good of a picture. So we've been using the lumbar because we see better. But the SI joint question is a good question. The SI joint's further down. So if you're asking, could the SI joint cause back pain? Yes. Could the SI joint be causing this patient's pain? No. We don't just kind of guess. We make sure we know where the pain's coming from before we operate. Scope's not on. There it is. Grab her. Bunch of inflammatory tissue there.
Oh, towels, please. Yeah. Yeah, not here, over there.
Okay, take it. All right. Let's get started.
Wait, the panel is there?
You know how to double bag these?
Not this one.
Huh?
No, not this one. I wanna redirect the water over here. Try to save on that.
They're not cheap, are they? Huh?
Try to save one bag, but
Yeah, they're not cheap. Are they?
lights off, please. Thank you.
Okay, I'm feeling, and what I'm feeling is the bone. And again, it's like I'm coming down a ski slope here, and at 11 o'clock, that's where the mountain is, 11, 12 o'clock. And you want to slide right down the mountain, and you end up on the facet joint. I mean, you end up on the transverse process. You start on the facet joint, you end on the transverse process. And that's where we are. We're kind of docked right at that junction of transverse process and facet. See that right there? That's probably the nerve that we want to cut. So now I feel like that was the nerve, but I don't want to just take a chance and it not be the nerve. So I'm going to look around a little more and make sure we get anything that might be a candidate as being the nerve. You know what I mean? Joe Green, I think that was it, but I don't want to take any chances and not get the nerve. So this over here is the facet. And like on the other side, there should be a screw. It's right there. See it? Covered in scar tissue. That's it right there. That's why it's creating sparks. The laser is literally melting the screw. That's how people want to know how powerful. See those cuts on the screw right there? That's actually from the laser. I just hit the screw with a laser. It melted it. Bam. Those bright flashes, lightning flashes, are the laser blasting the metal. Pretty cool, huh? So my job is to make sure I get that nerve cut right here. Anywhere it could be, I'm gonna get with the laser, just to make sure we don't leave it behind. I think I got it already earlier. I saw it, but I want to make sure there's no secondary branches, little branches that could still be there, because if that's the case, they could grow back, and I don't want them growing back. I'm trying to cut these nerves once and for all. So you can see the screw right there as well. Those are the screw threads going into the bone, right where the laser is now. Pretty cool, huh? Once again, I didn't do his fusion, someone else did. And he's had problems afterwards with the discs and now with his facet joint. So we're pretty much done with this. I don't see any more branches of the nerve. I'm just going out the transverse process, basically, coming across it, and I don't see any more branches of that nerve, so I think we've got it. Looks good to me. Some scar tissue. Remember, this is the L5 pedicle screw. Okay? That's the L5 pedicle screw. You can see it on the X-ray. We're pretty much done here. And that's the transverse process. So I've gone out the transverse process. I've gone across the entire surface. I don't see any nerves left to cut. We got them all. We're done. We're going to go to the last level, which is the sacrum, just like we did on the other side. I got that. Suction is on.
Scope off, please. Thank you.
I'll put a little pressure. We'll bring the scope back in. I'm using the fluoroscope. So once you place the needle, the problem is the needle can move around. So you got to keep checking because it's not really anchored in anything. And if you let it move and you don't recheck it, then you could end up in the wrong place. Shot. Looks good. Could probably be, it's pretty good. Could be a little more medial, but that's fine. All right, let's get the guide wire. Can you bring the fluoro up to the ceiling? Because you're a little too close to me. I feel that I'm on the sacrum. Wait. Shot. All right, looks good. This poor patient's been through so many procedures before he even got to him by other surgeons. Watch your hand. Shot. All right, just checking to make sure the guide wire has not moved. Shot. Yeah, it moved a little bit, but we're okay. Shot. Looking pretty good. Shot. Looking really good. Okay, take it. All right. So we're sitting right on the back of the sacrum or tailbone, right where the S1 facet joint is. And I apologize for not being able to see much, but this is unfortunately needs to be done with what's called AP fluoroscopy, which is where I bring the fluoroscope in, you know, from the top, so you can't really see. I don't mean to do it that way, but that's just the way it has to be done. So that's perfect. All right, let's get the scope out. So once again, I'll be looking at the side of the S1 superior facet on the right side, and I'll be looking at its lateral surface and then peeling the nerve that's causing pain right off of that thing and cutting it with a laser. Let's see the grabber. This is 5 more minutes, doctor. Okay. Alrighty, good. There's some tissue there. Let me see. The IV bag is sort of in my way. The IV bag?
The IV bag?
Uh-huh.
Oh.
There's a little nerve branch there. Again, I'm coming right across the bone where the nerve is, and I'm using the laser to cut through. That's what bone looks like when you zap it, by the way. You're right there. See the bone there? See what we got here. Looks like fat. It's definitely a crystal, a lens.
I will check.
Oh, by the way, somebody asked about the SI joint earlier, and I just want to say this can also be used to treat the SI joint as well. The endoscopic procedure that we're doing. I don't see any more nerve. You know? Let me have the grabber.
Yes, sir.
Just about done. Maybe 1 minute. Just want to make sure.
Please.
Let's check the fluoro position one more time. I'm good.
You can put fluid over there.
Shot.
You can leave it there.
I cannot. Is that it up top?
Yes.
Can we do a better shot than that? Come south more. Shot. Yeah, it looks good. All right, let's go out. One more look. Yeah, you got to get a bag on both sides if we're going to go bilateral.
Because it's more medially.
No. Grab her.
Thank you.
All right. Should be it.
All right, lights on, please. Scope off, please.
Well, it has been interesting. And now you've seen endoscopic surgery done for not just disc problems, but also problems with the facet joint. Yeah. It's all right. It's all right. It's all right. Hey, we live and learn, right? I would say we just need 2 bags, one on each side. Isn't there a U-drape?
This is one U-drape. It's just I try,
Mhm.
but yeah, no.
But the U-drape is for down here.
This is actually, yeah. I
Yeah.
can use this for the cervical and cover.
I think you're just going to need to do 2.
So what I can do is just like cut this one in half and try to improvise.
Is there another nipple here for...
Yeah, right here.
Yeah.
So I can cut this one in half and improvise it. That's it.
You know, play with it a little bit, see what you can do. I mean, if you were to... Where's the other nipple? So if you were to cut if you were to cut here, you could probably open this and spread it over here. But anyway, we're just trying to figure out how to get good collection on both sides of the patient when we're doing a bilateral procedure. Bilateral means both sides. We're done, doctor, by the way. So we got one more surgery to do. And we're going to come in here for that, or the other room? The other room. So we're pretty much done with broadcasting then. We've started splitting our surgeries up into 2 rooms to reduce the amount of time in between cases and use 2 rooms. But the other room's not equipped with broadcast ability. You ready? So basically, we can't broadcast the last case. That said, I hope you've enjoyed the surgery. It's a interesting new type of pain management procedure. Instead of doing a needle RFA, we're doing an endoscopic laser. I think the results are going to be better because we can actually see all the tissue, and the laser is far more powerful than just a probe that heats up for a few seconds. I'm going to call EBL 8 mil.
Disc herniations are a common cause of chronic back pain.